Welcome to this presentation in the context of the ERN World Heart. This presentation is dedicated to dilated cardiomyopathy, especially focused on inherited DCM. My name is Philippe Charron. I am working in Paris at Pitié-Salpêtrière Hospital. So we speak about dilated cardiomyopathy, which is defined by the presence of left ventricular dilatation and left ventricular systolic dysfunction in the absence of abnormal loading conditions or coronary artery disease sufficient to cause the global systolic impairment. And this was according to the last update of the classification of the cardiomyopathies. The cause is often considered as unknown, but in fact the etiology is highly heterogeneous, as you can see here, with infection, toxic, metabolic causes and others. And we can say that familial or genetic origin has been underestimated for a long time. But we know now that dilated cardiomyopathy is a familial disease through echo screening in the family. So a familial disease in 20 to 35%, so at least 1/3 of DCM are familial. And similarly, we know that the yield of mutation screening is now between 35 to 50% with the analysis of large panels of genes. There are more than 50 genes responsible for DCM, coding for various cellular compartments and pathways. The mode of inheritance is usually autosomal dominant, although others are possible. And three genes are more frequent. The titin gene, the most frequent one, about 20% of DCM. And then MYH7, beta-myosin heavy chain, and lemmin AC gene we will speak more about. The pathophysiology may be different according to the genes, but experiments about titin mutations demonstrated a loss of function with sarcomere insufficiency and decreased contractility. This is well demonstrated in this paper here, and similar mechanism for beta-myosin heavy chain mutations. All this knowledge led to a revision of many concepts about dilated cardiomyopathy. One interesting one is related to the penetrance of the disease. Familial DCM is a genetic disease, but with a delayed cardiac expression. And you can see here the delayed age at onset in family members in the French cohort. And on the right portion of the slide, you can see the opposite presentation of lemmin carriers free of disease expression. And as a whole, we can say that DCM is quite rare in young children. And it usually appears during adulthood, and the occurrence may be very late, sometimes only at 60 years of age. Another interesting concept is that the presentation and the prognosis of the disease may vary according to the gene. And this is well illustrated by lemmin AC gene. There is a particular phenotype associated with this gene, with early conduction defects or arrhythmia, usually in young adults, and then later on DCM occur. And some patients may also have skeletal myopathy, but not all. The prognosis is very poor in these patients with very high mortality. You can see here the Kaplan-Meier survival curves in DCM patients with or without mutation in the lemmin AC gene. And this high mortality is especially due to AV block and ventricular arrhythmia. And this was confirmed by this large meta-analysis of more than 8,000 DCM patients with this gene, especially associated with high rate of sudden death due to conduction defect or ventricular arrhythmia. So the consequence is that pacemaker and ICD should be discussed very early in these patients. Predictors for sudden cardiac death or malignant ventricular arrhythmia have been identified in this paper with 4 independent predictors: non-sustained VT, ejection fraction below 45%, male gender, truncation mutation, and more recently a new modelization was proposed, including also conduction defect. So a specific risk stratification should be used in the presence of DCM related to this gene. Other genes are also associated with bad prognosis, especially phospholamban and filamin C. Another concept is that apparently acquired DCM may have a strong genetic component, especially through gene-environment interactions. And this is the case for peripartum cardiomyopathy. In fact, some data show that the systematic screening of relatives may identify some DCM. And also interestingly, some papers such as this one show that systematic genetic testing in women with peripartum cardiomyopathy may identify pathogenic mutation responsible for DCM. And it is not rare. You can see truncating mutation in titin was identified in about 15% of these women. And a similar concept is now also proposed for myocarditis and for alcoholic dilated cardiomyopathy. So, what are the implications of this knowledge for the practical management of the patients with DCM and the families? We will speak about the diagnostic criterion, the diagnostic workup for the etiology identification, and the etiology-directed management. And this will be especially based on this European consensus document that was published in 2016. First, it is important to recognize the natural history of the disease and the large clinical spectrum of dilated cardiomyopathy, with a preclinical phase without cardiac expression, so mutation carrier, and then mild cardiac abnormalities may occur, such as isolated ventricular dilatation, or arrhythmia, or conduction defect. And then the obvious phase of systolic dysfunction with or without LV dilatation. And therefore we have introduced the entity hypokinetic non-dilated cardiomyopathy. Diagnostic criteria were refined in this document for index patients with the distinction between dilated and non-dilated, and especially for relatives. Several major and minor criteria were proposed to take into account the early stage, the mild abnormalities, and they were combined to be able to conclude about definite, probable, or possible disease here. Another important objective is to use a systematic approach for the diagnosis of the underlying cause of DCM. And this can be based on 3 steps. First, a basic evaluation, very simple examinations. 2, the careful examination of this first line examination, searching for atypical features, red flags, that are suggestive of a specific etiology. And then third step, to perform a second level evaluation based on the hypothesis to confirm or not this hypothesis. Here are some examples of important clues or red flags that should lead to the suspicion of a precise etiology. For example, in the presence of intellectual disability, to think about dystrophinopathy, mitochondrial disease, and especially to carefully examine the ECG. The presence of AV block is suggestive of laminopathy, myocarditis, sarcoidosis, desminopathy, and myotonic dystrophy, for example. And this is a similar approach with echocardiographic findings, MRI, biology, and so on. Some precise recommendations have been made for this diagnostic workup in patients with DCM. Of course, coronary artery disease should be excluded, especially in patients more than 35 years of age. First-line laboratory testing should include basic parameters that are mentioned here, quite basic but very important. Second-line diagnostics should be targeted to the suspected etiology. CMR, cardiac magnetic resonance, is now performed quite systematically and can provide very important informations. Endomyocardial biopsy is discussed on a case-by-case basis. Interestingly, it is recommended to perform a cardiac screening of first-degree relatives with ECG and echo, irrespective of the family history, as a mandatory step in this diagnostic workup of DCM. And finally, genetic testing is largely recommended, especially in the presence of a familial form of DCM or in sporadic case, especially with atypical clinical clues suggestive of a particular genetic disease, such as AV block, CK elevation, and so on. Finally, the correct diagnosis of the etiology of DCM should lead to an appropriate etiology-directed management. First part is to continue family screening if familial or genetic origin is confirmed, to continue regular cardiac screening of first-degree relatives from childhood to 60 years of age, regular cardiac screening every 2 to 5 years of age, to propose and perform predictive genetic testing in relatives if the causal mutation is identified in the index patient in order to guide the cardiac follow-up in the relatives, and to provide the opportunity for therapeutic specific management of the patients based on the etiology, including the early implantation of ICD or pacemaker according to the genes, and sometimes in very particular cases to propose. So as a conclusion, my take-home message is to underline the recent advance in the understanding of genetic basis of dilated cardiomyopathy. At least 1/3 of DCM are familial forms. The yield of mutation screening is now about 50% with next generation sequencing on panels of genes. Think about delayed cardiac expression, sometimes phenotype-genotype correlations, the role of genetics in some acquired DCM. And it is important to integrate this genetic data to improve the management of the disease, to perform cardiac screening in first-degree relatives, at least once, irrespective of family history, to perform genetic testing, especially in the presence of a familial form or sporadic cases with atypical features. And finally, the importance of etiology-directed management, including early ICD or pacemaker. Thank you.